On to you, sir.
Yeah, thank you for the introduction, and thanks Dr. Chitra Madam and Dr. Muralidhar for the opportunity. So I'll be talking about the basic evaluation of strabismus. So what are the ultimate goals after a complete strabismus evaluation is to first find the cause of the strabismus. The first and foremost thing to rule out is, are we dealing with the real case of strabismus, or it is pseudo strabismus which the patient is complaining about, whether it is congenital or acquired, and the comitant, paralytic, or restrictive pathology is the reason for the presenting complaints. Next is the management part. We need to have a complete and accurate measurement of the angle of the deviation for further management surgically. So whether the squint has affected the stereopsis and binocular single vision of the child, and sometimes depending on the preference pattern, we can detect amblyopia also in these kids. So this is the general guidelines we follow. We start with the history of the presenting complaints like squinting. Then we'll continue with the visual acuity estimation, which is already covered. And then the proper strabismus evaluation part, which I will be discussing. And all the children has to undergo a complete cycloplegic refraction under fundus examination. And few special tests can be added as and when necessary, depending on the presenting complaint. So this is the thing which I'll go about. We'll deal about the motor evaluation part of the strabismus, and then the sensory evaluation. Special test I'm not covering much because of the want of time. Diplopia has short 3-step test, and FDT, FGT can be covered under paralytic strabismus when Dr. Rohit sir is giving a talk. So I'll be dealing with the basic evaluation part alone. So it starts with abnormal head posture. The moment the child enters the clinic, it's always better to have a look at the posture which the child is coming with. It should be normal, erect and straight. Any abnormal head posture, being it a head turn, head tilt, whether chin is elevated or depressed, gives a clue for the diagnosis, and then we can start examining in that direction. Next, the common test which is used is the Hesberg corneal light reflex test. Here, the patient fixates light, which is held at 14 inches at the glabella, and then the examiner has to look for the light reflex in both eyes. Usually, when the light reflex is centered, it is normal, and when the light reflex is decentered, either nasally or temporally, we can make out the presence of squint. So normal thing which we pediatric ophthalmologists follow is the 1 millimeter of decentration is equivalent to 7 degrees of arc, and which corresponds to about 15 prism diopters, which is calculated with this picture, like considering the pupillary size of 4 millimeter and the corneal size of 12 millimeter, we come to this derivation. But Rosenbaum, after having a photographic calibration studies, they have come to a conclusion that 1 millimeter of decentration, they calculate to have a 21 prism diopter of deviation. But normally I follow this normogram of 1 millimeter of deviation displacement equivalent to 7 degrees for most of the cases. So this is just an example where the Hesberg light reflex can be interpreted. So it can be either at the pupillary margin, where it corresponds to approximately 15 degrees or 30 prism diopter, or it can stand somewhere between the pupillary margin and the limbus, where it is approximately equivalent to 30 degrees or 60 prism diopter, or at the limbus, which is considered to be having a 90 degree of deviation, 90 prism diopter of deviation. These are a few of my patients where we commonly take a photograph of the patients when they come in and before examination, because most of these young children doesn't cooperate for proper squint evaluation. So I depend on mostly on the photograph, which clearly, if you have a good camera with you with a good mobile phone, we can capture the Hesberg light reflex in the camera. Based on this, I operated few cases. These are the a few children which I operated wholly depending on the photographic evidence which show the Hesberg light reflex. And I couldn't do a proper squint evaluation for this child, squint measurement for this child. So the next group of tests is called cover test, which includes cover, uncover, and alternate cover. We need a good visual acuity in both eyes, good ocular movement, foveal fixation, and of course, attention and cooperation of the children for the test to be completed successfully. So for a good fixation, we'll know that we need a foveal fixation, and all accommodation should be controlled to get a good workup of the cover test. For that, we need to use accommodative toggles. Torchlight should be avoided in such cases, and the fixation target should be good enough that the patient's more than the patient's visual acuity. And all the cover and uncover test, everything squint evaluation has to be done with full spectacle correction after correcting the refractory error. Fusion and vergence should be eliminated. When we are doing a prism bar cover test, we should be very careful. We shouldn't allow the child to fixate at any point of time. Sometimes patch test can be done to control the fusion in cases of intermittent exotropia. Cover test, as you all know, is to detect the tropia. We cover one eye and look for the movement in the other eye, which shows the presence of tropia. And cover uncover test is to detect the phoria, where we cover one eye and look for the movement in the same eye when uncovering it, which will bring out the phoria component of the squint. And alternate cover test, where we don't allow the child to fuse at all, will give the measurement of the total deviation that is both latent as well as the manifest. Extraocular movements is very important. We have to do separately ductions as well as versions. Duction is elevation, depression, adduction, and abduction. And we should have all 9 cardinal position of case version movements to know which muscle is affected, which muscle is overacting. All these things should be noted down in the case sheets. Next, foremost important test is a Prism cover test. It measures the squint. Again, for this, we need a 4-wheel fixation. Visual acuity should be good enough for the patient to cooperate to fixate at the targets. Accommodation should be controlled, as I already mentioned, and one eye must be always covered. We shouldn't allow the patient to fuse at any point of time. And this very basically, we know that apex of the prism is kept towards the deviation, and the amount of prism power required to neutralize the eye movement is the measure of deviation. I just wanted to add few factors which can go wrong when we do a complete measurement. That stacking of horizontal prisms should not be done. Most of us are aware of that, but vertical prisms can be stacked over the horizontal prisms. Large angle measurements, when we deal with more than 90 prism diopter, we need to split the prisms in front of the both eyes. But at that circumstances, we have to follow the tabular column, which is given in the Rosenbaum, that the addition of the prisms is not equal. When we keep 40 prism diopter in one eye and 20 prism diopter in the other eye, the actual total angle which has to be dealt is 65 and it is not 60. So we can take reference from the Rosenbaum. And as you all know, the peripheral prism effects can be there when we measure the prism deviation, squint deviation with the help of high hypermetropic or high myopic glasses, usually more than 5 diopter of glasses. So again, Rosenbaum comes out with a table, of high hyperopic glasses, where we have to clearly look into the tabular column and make some adjustments. And pattern deviation is, again, you have to measure for up gaze and down gaze, and primary and secondary deviation also should be dealt. Krimsky test is used when there is a poor fixation. Here, either modified Krimsky or Krimsky can be used. The prisms kept over the fixing light and look for the centration of the deviated light. So sensory evaluation squint, I can touch upon this. There are 3 components: binocular single vision, stereopsis, and sensory adaptation. Sensory adaptation, I'm not going into detail. Worth photo test, which is the common test which you all are aware of. Stereopsis is more of near and distance. Near, we commonly use Titmus fly, Dandam dot stereogram, and Frisbee and Lang stereo test. Distance stereopsis is most commonly used for cases of intermittent exotropia. And cyclodeviation is not routinely done, but when there is a torsional complaint, we have to look for subjective test or objective test. And to complete, I have to emphasize this point that squint evaluation is not complete without a good cycloplegic refraction and the correction of the refractive error. And dilated fundus examination should be a part of the routine squint evaluation. Thank you.
Thank you very much, Dr. Rajesh. Very crisp talk. So we go on with our moderator questions.
Yeah, we have some audience questions for you, Dr. Rajesh. One is, yes. What is your cycloplegic of choice in children with strabismus? Let's say you have an older kid with strabismus and with exotropia precisely, and you are able to determine the best corrected visual acuity and acceptance. This is the first time you're seeing him. Would you still insist on cycloplegia?
Yes, cycloplegic repression I do for all the routinely for all these strabismus patients, whether it is esotropia or exotropia. For younger children, I would like to do with the 0.5% of cycloplegic. And atropine nowadays, for want of availability, I don't use. Previously, I was using atropine diffraction with the help of atropine ointment for very young children with accommodative esotropias, with the esotropias particularly. But now I think, I don't know, atropine ointment is not very easily available. So I stick on with cycloplegic refraction alone.
For older kids with exotropia, whom you're seeing for the first time, would you still insist on a cycloplegic refraction?
Yes. First time, I always go ahead with cycloplegic refraction.
And would you test stereo acuity in very young kids, let's say 1 to 3 years? And
it is not possible. It is not possible. They might not be cooperative. So I don't go ahead with the sensory evaluation part as such. Maybe sometimes they might cooperate for a worth for dot test. Otherwise, usually stereo test is very difficult to interpret.
And There's one more audience question. That is, you have a child, you have a 4-year-old child with exotropia, vision in the right eye 624 and the left eye it is 66, with the right eye inferior oblique overaction. So the question is, when would you recommend, what treatment would you start? There's no significant refractive error. What treatment would you start, and how soon would you consider this child for strabismus surgery?
I think we need to find out the reason for 624 vision, whether it is strabismic amblyopia or anything else. As you said, the refraction is normal. More likely, it might be a DVD or something which is causing the amblyopia. So I treat amblyopia first. Maybe such patients with less visual acuity, I would like to postpone the surgery to maybe around 15 years. I don't opt for a younger, earlier surgery in such patients. I would like to treat the amblyopia part first.
Any comments from the expert panel? Rohit sir, Pradeep Sharma sir, SG ma'am, MS ma'am, SAR ma'am?
I just wanted about this using corneal reflex test. Sometimes if there is a large positive angle kappa or a large negative angle kappa, it can sometimes confound your squint findings. So I think you should attempt a cover test before
Yes,
at least.
yeah, but very young children, like last week I operated a 1.5-year-old child. So sometimes, and I take these patients only if there is a large angle, ma'am. I don't take when there is a small angle.
I know you do that, but I'm just making a point there.
And I tend to undercorrect little bit. I don't usually do my usual numbers. I tend to little bit undercorrect to such patients because no other choice to. The moment we take the prisms, they just don't cooperate at all.
Should be done with a little bit of pinch of salt.
And the Lang's 2 pencil test is something which you can do even with a child who is 1 year plus. They can play with your pencils and they would do it. So
Yes,
you will come to know even post-op if the eyes are in alignment and if the binocularity is working or not. So that's a full test which should be done as a bedside.
Yes, sir.
Yeah. Can I ask a question?
Yes, please.
Yeah, I just wanted to ask the panel regarding, of course, cycloplegic refraction we are doing, but in which cases would you suggest an orthoptic evaluation in children, even if they are emmetropic, like specifically for headache or eye strain? A lot of patients and parents bring their kids for these reasons. Would you advise that, or is there any other indication?
Can I take that question? I think evaluation is a part of comprehensive eye examination for every child. So strabismus should be looked for in every child who comes to you for clinic. A detailed orthoptic evaluation, which means that probably you have to base it on symptomatology of the patient. If there is a clear reason for eye strain or symptomatically patient has asthenopic symptoms, then definitely you can do. But again, orthoptic evaluation not very easy. Detailed one is not very easy in very young children. Let me tell you, probably 6 years and above, you can rely on what you get on your orthoptic evaluation. But apart from that,
may I add a point?
Yes.
Yes, ma'am.
Answer Dr. Anaga's question about. I think you're absolutely right, Dr. Anaga. I would include the orthoptic evaluation if you have done a thorough examination and have not been able to find any refractive error, or you've not been able to find any other cause for headache, no strabismus, then you think if the child is comprehending and you will be able to get a reliable response, yeah, definitely you can attempt, because convergence insufficiency is one of the most underreported and overlooked cause of eye strain and headache. And that is something that can be picked up reasonably easily and can be treated also reasonably easily. With the increasing gadgets these days, all online classes, we also find a lot of accommodative problems, accommodative excesses. So I think you're even hinting at a glimpse of the future. We may be seeing more and more kids complaining of these kind of things. We may have to do some basic orthoptic evaluation in all these kids who have eye strain. You're right.
This is just a message to all the general ophthalmologists who, otherwise it's just the autoref that is done by the optometrist, and if it's emmetropic, they just say there's nothing wrong with the eyes. So this
Correct.
might just go undetected. That's why I thought.
Just very simple NPC,
Right.
accommodative NPA, accommodative amplitude. That's all you need to do really.
Yes.
But only after an age-appropriate cycloplegic refraction.
Right, definitely. That
So
goes with
that
us.
is, as you said, that they do an AR and often not a cycloplegic AR. So the most important cause would be refractive errors. And unless you eliminate that and you give them orthoptic exercises or things like that, you may actually worsen the patient if he's, say, hyperopic and he continues to do exercise. So first cycloplegic refraction, then orthoptic workup.
And just add one more thing. In fact, you would actually need atropine sometimes to break this accommodative issues which are coming up because of these screen time and all. So atropine actually is a very good drug in our armamentarium. We just can't, kind of ignore it. So maybe it is difficult to procure, but you have to have atropine to be used sometimes, especially in the younger children.
Meenakshi madam, I have a question.
Yes.
I had a patient around 14-year-old came with convergence weakness, which is very mild, not very obvious. I have a patient had a prescription with him of base in prisms of 1 diopter in each eye. Patient is from Australia. So what would you recommend to do? They have not done any exercises. To start with 1 pen and 2 pen exercises, or straight away to go ahead with prisms?
No, I would not put the child in Prism. Child in Prism, because patients who have, say, small exophoria or have convergence weakness, sometimes they will start accepting the prisms more and more. The prism may be given temporarily just for tiding over. Say the patient has exams, has to read for exams, a lot, very symptomatic. So just to tide over that period, you can give prisms. But otherwise, these children do need proper exercise guidance. Yes.
I also did the same. I stopped the prisms and started on convergence exercises.
Yeah, absolutely.
Thank you.
Thank you.